Welcome to Advanced Patient Care, the exclusive podcast series by Vance Thompson Vision. Our purpose is to keep you at the forefront of patient care through dynamic insights, practical clinic tips, and engaging expert discussions. Join us on a journey of continuous learning and professional growth as we delve into the latest advancements in ophthalmology and optometry. Our mission is clear: empower eye care providers with the knowledge and tools needed to deliver exceptional patient care. The Advanced Patient Care podcast is dedicated to elevating our craft, one episode at a time.
So how do we approach the glaucoma patient that is ready for some type of surgery? Well, before that, let's think about where we get before we go to surgery. If you have a patient that has glaucoma and you're wondering what's the first step, almost always the first right step is SLT. Drugs aren't terrible, eye drops aren't terrible, but if it was my eye, most patients, most doctors would say the right place to start is SLT. Now, where do you go after that? You could go to an eye drop to see if you get an additional drop there, but what we don't know there is did the patients actually take it, and they almost all come with at least some form of side effects over the long term. As we move into the surgical realm, and what I mean by that is surgery inside the eye, MIGS is always the first choice inside the eye, except for in very uncommon situations where the glaucoma is a very specific type, or if that glaucoma is so advanced that they're just hanging on by a thread. MIGS, of course, stands for minimally invasive glaucoma surgery, and that usually encompasses trabecular meshwork surgery. So the fluid is produced, the high point of resistance is typically the trabecular meshwork, and we're going to open that up somehow. Either we put a few small stents in the trabecular meshwork, maybe we do a goniotomy where we remove the trabecular meshwork, or maybe we do a transluminal dilation in addition to a goniotomy. Sometimes we add endoscopic cyclophotocoagulation, although for me, I usually only do that in the already pseudophakic setting in combination with a goniotomy. How do I kind of think about which surgery's right for this individual patient? Well, I usually think of the eye stent as the least invasive, and then a goniotomy plus ECP is the most invasive, and then perhaps hydrus right in the middle. And I think that in general, you're going to find that the efficacy is similar and the safety is similar, with a little bit of a tilt towards a little less efficacy with eye stents and a little more safety with eye stents versus a little bit more efficacy with goniotomy and maybe plus ECP, with a little bit more complication of hyphema or a cyclodialysis cleft. And that's how I approach it. I don't really think that the patient should decide this because it's so nuanced. This is really a doctor decision saying this is what I think is the right next move for you. Now, I think two big categories are, do they have a cataract or do they not? Some of this is, I wouldn't say dictated by insurance companies. Insurance companies don't get to decide what we get to do. We took an oath to the patient, not to the insurance company. We also didn't take an oath to the label. I want to think through what is the best surgery for this patient. Then we think what's best for this patient's life. And that could come across as, well, what will their insurance cover? That may be what's best for that surgeon's life, but I can assure you the insurance companies are not a better decision maker than we are on what's best for patients. And so what goes into that decision? Well, is it going to get the eye pressure low enough? What kind of safety risk am I going to take with that? How long till recovery? And is it going to get paid for by insurance companies are really what goes into that. And then maybe if I do this surgery, what's my next move? And do I still have moves down the road if this surgery wears out over time? And so in our practice, we find that for a patient that has a cataract, very frequently and most commonly an eye stent is our move. Occasionally it's a hydrus, occasionally it's a goniotomy. As we move to more pseudophakic patients, then it's more often a goniotomy or or sometimes an iStent Infinite where you get 3 stents. And frequently we're adding endoscopic cyclophotocoagulation along with that. Side note, I always inject a bit of steroid at the time when I do that. So that's how I kind of approach these patients. And then if we started with iStents and it didn't get us there, or over time it's not all the way there, then what I move to typically is a goniotomy and an ECP. And if that doesn't get us there, then we're going subconjunctival and we move into more the space of Zen or a tube shunt or something like that. Now there's one additional wrinkle to this, and that's intraocular drug delivery. So treatments like Durista and iDose now put the prostaglandin inside the eye and not on the surface of the eye, so you don't have to worry about the side effects as much. But you do have to go inside the eye, with the Durista lasting maybe 6 to 12 months and the iStent or the iDose lasting about 3 years. And so we've been using that more and more frequently, and it can be used across the spectrum of disease with pretty wide reimbursement. So you have a lot of latitude on when it's the best thing for the patient. And that's our preoperative considerations. Thank you very much.
Hey everyone, really excited to talk a little bit about what to expect after minimally invasive glaucoma surgery. These will include procedures such as stents, canaloplasties, goniotomies, and there's really 4 to 5 major points that I think of from a post-operative perspective with these procedures. The first thing that we're going to run into is these patients have glaucoma, and so their drainage system, trabecular meshwork, is not as functional as what a normal eye is. And so within the first week to month to even 3 months, these patients could have intraocular pressure spikes. We're all comfortable with managing these. There's a variety of different ways we can manage these. Sometimes it's a matter of adding additional glaucoma medications to lower the intraocular pressure. For me, if it's a day 1 intraocular pressure spike, a lot of times I'll go ahead and burp the wound. If you're not comfortable with burping the wound, then I think adding additional medication, whether it be topical or even oral, matters. You also have to take into account the level of glaucoma that you're dealing with. A patient that has very mild glaucoma, that has a small intraocular pressure spike, we probably don't need to intervene as aggressively. If it's a patient with moderate to severe glaucoma with an intraocular pressure spike, we need to intervene more aggressively. And so managing the intraocular pressure spikes is crucial in that post-operative period. The other common thing that comes up in the post-operative period with MIGS is, when do we stop topical glaucoma medications? My rule of thumb is typically waiting till the 1 month mark after surgery to start peeling away topical glaucoma medications. I do this because that first month, these patients still typically will have some steroid that's been placed inside the eye. They'll typically be on some topical steroid as well to manage some of the inflammation. And we all know that with steroids comes elevated intraocular pressure. And so if I can blunt that pressure spike, or I can blunt some of that increase in intraocular pressure, then I'm doing a favor for that patient and likely controlling the glaucoma a bit better. And so I like to start peeling a medication off one at a time at around 1 month, as long as I'm at the target pressure that I set for that patient preoperatively. The other thing we'll deal with in the postoperative period after MIGS is hyphema. These patients often, whether they're stented, whether a goniotomy is performed, whether a canaloplasty is formed, will bleed a bit after these surgeries. The hyphema is almost always self-resolving. And so it's a matter of educating patients on the front end that they likely will get some microhyphema or hyphema in their eye. And it's a matter of talking to them after surgery as well at their day 1 postoperative visit, that the reason their vision's a bit cloudy is likely from that hyphema or microhyphema. I tell patients that all they need to do is continue to take their post-operative medications, both the ones that we prescribed as well as their topical ocular hypertensive medications, and to continue on in life. This cloudiness will fade at about a week or so. Day 1, we talked a little bit about pressure spikes, hyphema. Week 1, same type of thing. But what patients need to understand is that likely they won't reach their target pressure, or we won't know the efficacy of the MIGS procedure until we get about 3 months post-surgery. It's a very important piece because, as we all know, patients, when they come into our clinics, the first thing they want to ask us is, well, what's my intraocular pressure? And if it's elevated, they're going to think that these MIGS procedures have failed, when really a lot of times it just takes time for certain patients' eyes to settle down to reach a point where they're at that steady state of what that MIGS procedure did for their intraocular pressure. The other really important post-operative MIGS procedure that we should do as doctors is gonioscopy. I usually like to do gonioscopy one time in the 3-month post-operative period just to make sure that the stent is functioning properly, that the goniotomy is open, that there's not anything that's impending or creating a problem in the angle of the eye. And then I recommend doing gonioscopy one time per year to, again, just make sure that the MIGS procedure that was performed is functioning appropriately.
Thank you for tuning in to Advanced Patient Care, the exclusive podcast by Vance Thompson Vision. Want to learn more? Schedule a personalized mini fellowship at one of our clinics where you can gain hands-on experience and real-world applications tailored to your practice. For more resources and information, visit vancethompsonvision.com/OD. Let's continue advancing patient care together, one episode, one innovation, and one patient at a time.